Welcome to the American College of Correctional Physicians, ACCP's YouTube channel, where we explore the ever-evolving landscape of correctional healthcare with leading experts in the field. I'm host, Dr. Susan Rashid, and today we are privileged and honored to welcome Dr. Charles Lee, the past president of ACCP, whose visionary leadership continues to shape the standards of incarcerated medical care in this unique and challenging environment. In today's episode, we will be delving into Dr. Lee's invaluable experiences, discussing the future of correctional healthcare, and addressing the pressing issues that affect physicians and patients in this unique field of medicine. Dr. Jeffrey Keller, the current president of the ACCP, will be my co-host today. Jeff and I will be asking you questions today, Charles, and Jeff will start off with our first question for you today.
Okay, yes, my good friend Charles, you started out as a radiologist. Well, we all came to correctional medicine from somewhere else, but you started out as a radiologist. How did you end up in correctional medicine?
Good question. It was an interesting journey. I was a radiologist here in San Diego for about 20 years. And I got tired of looking at mammograms, ultrasounds, doing barrier minimas. So I decided that enough was enough. Since I'd gotten my doctorate degree, my Jewish doctorate degree, and the MBA, I felt I should turn more toward an administrative executive role rather than being down in the pits. I came across an opportunity to join a radiology management company in Florida, Tampa, Florida. I jumped on that. Meanwhile, I went out there and was doing management of radiology, and suddenly the firm closed. And there I was, 3,000 miles away from home, no job, not knowing what was next in my life. Since I had gotten an MBA, I was a member of the Physicians Executive Organization. I would get a periodical occasionally. And in the back of that, it has classified ads. So I'm sitting in my living room, thumbing through it, and came across an ad for a physician executive for the prison system, the California Department of Rehabilitation, Corrections and Rehabilitation. And I said, hey, that might fit me. It would encompass all of my training, my skills as a physician, as an attorney, and as an executive business. So I contacted them, told them that I was interested. And they said, all right, come on out and let's do an interview. So I flew here to San Diego and got together with a couple of the executives, and they were interested. They talked to me and said, hey, we'd like to show you around. So they put me in a little airplane, a one propeller airplane, and flew me up to Pelican Bay and told me all about Pelican Bay. And I said, I'm not sure if I want this, because that's located at the far north portion of California. Then they took me down to Monterey County, which is a beautiful area in California, and showed me a prison. Took me there, and I met with the warden. Nice guy. We got along together well. He told me what the need was. He told me the type of facility it was, and told me what my responsibilities would be. I said, all right, this is nice. So I accepted it. And went down there and started working there. Now, the role that I had was not a clinical role. It was an executive/administrative role, which is exactly what I was looking for and exactly what I wanted. I oversaw medical, mental, dental, a pharmacy, medical records, and anything else that was present. And I loved it. I enjoyed it. Interestingly enough, when I got there, we had our first staff meeting. And I told everybody, I said, look, I'm not from corrections. I want 6 months to learn what this is all about. Everybody said, yeah, until the next day when they started asking me questions. I said, wait a minute, let me check into this. After about 6 months, maybe a year, I began getting a hold of what correctional medicine was all about. When I did that, I realized I really enjoyed the responsibility, the mission, and the goals for the penal system. So that's how I got from radiology to correctional medicine.
Charles, very fascinating journey in the field of correctional medicine and caring for incarcerated populations. What unique challenges did you face when you first entered correctional medicine, and how have those challenges evolved throughout the years?
One of the first challenges is acknowledging and realizing that once you go behind that gate and hear that gate close, you can't just turn around and walk out. You have to realize that you're in a system of an incarceration that has limitations, guidelines, and rules. Rules, for example, is being careful how you communicate with patients. Be careful what you say. Don't become overfamiliar. Now, that's true in the civilian life also, but it may be more so. And the other issue is respect. Learn to respect the patients that are there. I'm convinced they aren't bad people. They've done some bad things, but they want respect. And then I realized that if you do those things, that you will get respect back. Now, the challenge is cost. Cost is a big challenge. It's funded in the prison system by the Department of Corrections, State of California. And if you want something, you just can't pick up a order sheet and order it and expect to get it. You have to go through various levels of approval, and it has to be appropriate and necessary. And one needs to be able to justify and explain those things to the persons who will be paying for that, to the bookkeepers, to the purses, and be able to do that. The other thing is the limitations of patient movement in a correctional facility. They can't just jump up and run over and see you anytime they wish and want to. The other thing is the officers are there to maintain safety and security, and they are a vital part of what medical does. It has to be a collaboration. One thing that I found extremely valuable and important was working with the warden. The warden was a former Marine. I was former Navy. So we used to get together almost every morning and tease each other about who was responsible for who. And in doing that, we developed a relationship that if something was out of whack and I picked up the telephone and called him and said, hey, we can't get access to administrative segregation. They won't let us in. He would call his staff and say, hey, what's going on over there in Seg? We got to get the people in there for medication. And next thing I know, the doors were open. We were allowed to go in. So those are some of the challenges that a person from civilian life will encounter once they go behind that gate door.
Jeff, unmute yourself.
You had said, Charles, that you practiced in Monterey Bay. Is that the only prison that you were in, or were you in several?
No, that was the only one. I was there 10 years. I was what was called the health care manager. That was the role. They changed the title since the receiver took over, but I was the healthcare manager. Now, I visited many others. We had meetings, San Quentin, up in Pelican Bay, and many other places. We would periodically have meetings. So I went there and communicated with the healthcare managers there to discuss what their issues, their challenges, their problems were, so that we all could learn and benefit from that. But as far as actually being employed there, that was the only one.
Charles, incarcerated individuals often have complex healthcare needs due to a history of having inadequate medical access. How has your experience in correctional medicine shaped your understanding of healthcare disparities, and what changes would you recommend in improving these outcomes?
It's a good question. You know, people have said you can determine a person's health care and their longevity by their zip code, implying that if you're in the hood, so to speak, you're not going to have access to the same quality and the same extent of medical care as if you were in an affluent area. As you know, many of the patients there are from underprivileged areas, minorities, and historically, out on the street, they haven't had quality of care. They don't know how to request it or express their symptoms. Let me give you an example. One patient came up and said he had the sick as hell anemia, sickle cell anemia. So I had to be able to, or we had to be able to understand that. Pain. Our patients vary in pain. I mean, a lot of the patients in correctional facilities have undergone a lot of pain out in the street, gunshot wounds, stabbings, fights, and being able to express and acknowledge pain, because on the street, you want to limit how much you're crying because you're in pain. There may be a tendency to either do the same or exaggerate just to the opposite. Now they are free to say, hey, I got pain here, I got pain there. Now, we know that sometimes that's done in a manipulative manner. So we have to be able to judge. We have to be able to communicate patients maybe we did not encounter before, be able to almost talk their language or understand their language. So it is a challenge, particularly different races, different personalities, different people. Understand, what does that person mean when he or she says he's, got an aching down in the thigh, some area. Okay, what do they really mean? So communicating and understanding different ethnicities, different personalities is extremely important. Unfortunately, it sometimes takes a while to realize you got to do it and begin to try to do it. So it's a challenge with people who are different. And I put that in quotes. I'm talking about their backgrounds, their experiences, So it's different. And we as providers, and as well as the nurses, so anybody in healthcare in a correctional setting needs to acknowledge that and learn how to do that.
Jeff, do you want to ask Charles the next question?
It's on me. I guess that's true. So you were working. You had mentioned that you were there when the receiver took over control of the California prisons, and that is, I think, a unique event in the history of correctional medicine all over the country. For a receiver, for the courts to just wrest control of an entire prison system away from the state and then appoint a receiver to manage it. So tell us about that.
Very interesting. Pluses and minuses. When the receiver came, it was the attorneys, the prison law office, Steve Famer, who eventually he and I became friends, but not initially. And I'll talk about that in a minute. So the attorneys who knew as much, if not more, about the principles, guidelines than any of us knew. They knew them backwards and forwards. So they would come out. The first time they came out, they introduced themselves, and then we took them around. And one of the things that he asked me about was consultations. How far back is your backlog for consultations? Well, unfortunately, it was long, very long, for multiple reasons. Anyway, we toured the place, and he asked me, the way lawyers do, asked me questions. I responded. Then we had an exit conference. So all of the staff, of the leadership of the staff, was sitting at the warden's table, and Steve started. Trust me, he tore me to shreds. He said, I hadn't done this, I hadn't done that, I don't know anything about this, I don't know anything about that I was incompetent, and blah, 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 and the medical care there was disastrous, and et cetera, et cetera, et cetera, for a couple of hours. And I sat there trying to be cool, calm, and collected. I think I was. I didn't respond. I acknowledged what he had said. I realized what he was talking about. And I told him, I says, we will fix this. Unfortunately, shortly after, we had a meeting of all the healthcare managers and the main doctor for CDC. She came up to me and said, I heard about your report. We got to do better, which really frightened me. I thought that meant I'd be doing better someplace else. Anyway, I assured her, I said, yes, we will. I realized the issues, the challenges. So we went back to our staff with the information that we had gotten from the receiver's attorneys. And I says, we got to fix this. Bam, bam, bam. We started a committee. We had subcommittees. We had assignments and got working on it. On a subsequent visit from the PLO and from the people from Sacramento, which is the management for CDC, it was now CDCR. Originally, it was California Department of Corrections. They changed it, California Department of Corrections and Rehabilitation. They came back for a second visit. Same thing. This time, Steve and I and the people from headquarters walked around, and we showed the improvements that we had made. We showed the changes that had been done. And this time at the exit conference, one of the people complimented us. He said we had done an excellent job. And I don't know if he was playing us, but said he was retired. He said that if I came back to work again, I would like to come here. That made all of us feel, especially me, because now I still got a job, but that made all of us very happy. Now, the receiver had complete control of everything. One of the main things was salaries. He walked into the Sacramento at the legislature and told them what he needed to do, how much money, and et cetera. And he raised the salaries of everybody in healthcare. Consequently, things changed as far as getting people, more staff, more doctors, and especially more nurses. And it was welcoming as to see how that change improved the quality of care and made everything much better. So between me, you, and the gatepost, as my father used to say, I welcome that receiver coming and making the changes, not only in salary, but we did not have an electronic medical record at the time. It was still paper. And we all know the difference between paper and the challenges there. And one of the things that they mandated was to get an electronic medical record system. Actually, I retired prior to that being completely activated, but I was part, all systems, all facilities was part of giving input as to make that. So it improved the healthcare, the staffing when the receiver came in. And I welcomed it and was not happy that we were being sued, but happy of the consequences of that action.
Charles, correctional medicine requires balancing healthcare with the logistical and security demands of a prison or jail. How do you navigate these complexities while ensuring the dignity and health of our patients?
One thing that the warden who I mentioned and I sort of related and sort of understood each other did was he assigned a sergeant, a lieutenant, and an assistant warden, a deputy warden, to medical. And if I needed something, I would go to them. Now, the one part, it's not all custody, it's also us. We had to learn to work with them, to understand safety and security, to understand that there's a lockdown. You can't just go and do anything you want to do. So we had to learn that. I had to learn that there are rules and regulations, that between the two of us, we got to work together. I remember one time sitting in a department meeting, medical department meeting, in which there were those three custody people. And I said something about what we got to do. And the sergeant looked at me and says, "Doc, stay in your lane." And he was right. And I smiled and I told him, I said, "You're right. You're absolutely right. I'm veering into the opposite lane and I'm going to get hit." And then after that, he and I got together, talked, and we addressed the issue and problem and solved it. So to answer your question with custody, medical has to learn to work with, not against, custody. And custody needs to do the same thing in working with us. And once we do that on the same page, things will work.
Great. So you've been both in the free world when you were a radiologist, and then you worked in the prisons for quite a while. Which one gave you more satisfaction? What appealed to you? I assume that you had enjoyed your prison work. What appealed to you about it?
Okay, it's taking care of the people in need who have not been taken care out in the street. There were patients that would come in that had never been to a dentist. Now we can get them to a dentist. There were patients who walked in with high blood pressure diagnosed for the first time. Diabetes. Yeah, my mother had it. My father had it. I didn't know I had it. Asthma. Well, when I was a kid, they used to give me a thing to breathe. So that was what was very important to us, is understanding the population. I got distracted from my phone. I'm going to turn it off. But I hope I answered your question.
You did.
I thought I'd put it on mute, but I guess I didn't mute it enough.
Okay. I'll go on to a question I'm excited to ask you about. When we look at the intersection of public health and the jail and prison system, how crucial is the role and the field of correctional medicine in tackling current major public health challenges like mental illness, addiction, homelessness, and chronic disease management within the incarcerated population group?
Very, very important. One of the first things, particularly when COVID came about, I didn't communicate with the preventive medicine or the public health persons enough. All of a sudden, COVID hit us. And now we don't know what to do. So we realized vaccination, we realized information, we realized we got to do something, isolating, masks, et cetera, et cetera. That's when we and I realized the value and the importance of public health. Correctional medicine is public health preventive medicine. We have a large number of people contained in a sometimes small area. That's the opportunity for spreading of various diseases. Vaccinating is important. All of them, not just COVID, making sure they got flu, making sure that the PPDs, aren't positive. It was tuberculosis. That was another public health concern. So little by little, I believe that correctional medicine began to realize the value and importance of working with those people. One thing I did was I joined the American Association of Public Health Physicians and also the Preventive Medicine group so that I could learn. And when I was at the AMA delegate meetings, they were there. And we began to communicate and understand. They began to understand our problems. We began to understand what they have to offer to fix our problems. So I am totally convinced that public health and preventive medicine are the mainstay of correctional medicine, in addition to primary care, chronic care, not instead of, but in addition to chronic care. I was at one facility and 99% of the patients were locked down because they tested positive. Now, how do you manage that? Well, public health. We needed vaccines. All right, where do we get it? We go to public health and get it. So it's very important. That connection is extremely.
Well, Charles, you were the immediate president of ACCP and one of my heroes. Tell me about what that was like being president of ACCP. What did you accomplish? What were your goals? And how far did you get? What still needs to be done there?
Yes. Well, as we know, trying to manage physicians, as they say, is like herding cats. You got to do it wisely. You can't tell a doc what to do because he or she already knows everything. So you have to set up a scenario in which everybody works together. Docs work together, realizing that it's not an ego thing for each one of us, but a collaborative experience for all of us. And we have to have a gentle hand with docs. And I believe, and this is after 60 years of being in medicine, that docs' egos are somewhat fragile. And if you threaten it, you won't get the cooperation that we want. So that was one challenge, is managing physicians. Now, fortunately, I'd done it before. I did it when I was on a ship. They used to call me the SMO, SMO. I meant senior medical officer. And I had 4 or 5 docs that I had to work with. And so it was the experience. Now, goals. My goal when I started was to get the name of ACCP and correctional medicine to the public. My first AMA meeting I went to, I was at one of the round tables, and we were all introducing ourselves. Who are you? What do you do? Where do you come from? Et cetera, et cetera, et cetera. They came to me. I said, correctional medicine. I work in prisons and jails. And they looked at me as if I had some contagious disease. Now, so I took my time. I sat there, and I went through what we are, what we do, what we hope to learn, what we hope to gain. Now, as we all know, back in the day, docs who worked in the prison and jail had some issues with their licensing, and the judge said, all right, the only place you can practice medicine is in prison. And one of the things I told them, I said, it's no longer that way. We have fully trained docs and providers, nurse practitioners and PAs, who haven't had legal issues. I mean, there are many lawsuits. Our docs get sued all the time, but I'm talking about not illegal issues, drunken driving or bad outcomes of negligence. Negligence was another one. I says, we are trained and we are dedicated. All right. The next year I went, people, they saw me. Oh, hi, Dr. Lee, how is it? They began to recognize and respect a little bit more. By the time 3, 4, 5 years had passed, they would be coming to me, asking me stuff. that would help them. Maybe it was a public health issue. Well, what do you think about this? Well, what do you think about that? So it went from, I won't say disrespect, but little respect to what I feel was a lot of respect. As a result of that, I started getting some calls from various places to give presentations, to talk about correctional medicine. One of which that I am most proud of is the medical students. I got an email and say, hey, can you give a presentation to the medical student section about correctional medicine? I says, absolutely. I gave roughly about an hour. And they were interested. They were asking challenging questions, showing that they were thinking about it. How do you do it? How do you become that? What do you all do? What about the prison? What about the patients, et cetera, et cetera? And I felt good about having gone from who are you and what do you do and why do you do that to, quote, the correctional medicine expert who people would come to me and ask questions. And that's been my experience. I wanted to get the name of ACCP and correctional medicine out there. ACGME is in the process of granting correctional medicine as a valid specialty. Now, I didn't do all that, but we as a team did that. We talked to some of the preventive medicine people about board certification, and we had some challenges, which is, Jeff mentioned, what the future going on. I think we, as an organization and as a specialty physicians, need outside recognition. If we can get board certification through the American Board of Preventive Medicine, fine, but we may not have the numbers to do that. They have an alternative thing called a focused practice designation that may apply to that. That was something that I was hoping for, but it never panned out for a lot of reasons, some of which is time, others of which is we had other things we had to do as an organization. We can't do everything, but we did some things. So I gave a couple of presentations to the advisory committee on immunization practices. And this was when COVID came out. And I got my name in there and put it in. And fortunately, I think on 2 out of 4 occasions, I was given the opportunity to testify about COVID in corrections. And one of my main goals was to ensure that prisoners, inmates were in a high priority to get vaccination. Not at the last, after everybody else has gotten vaccinated. Oh yeah, let's give a little bit to the prisoners. No, we were moved toward the front, not all the way toward the front, hospices and people with severe illnesses deservedly got priority, but we were up there. Same thing with masks. Who should wear masks? So I think that one of my accomplishments was to get the word out there as to who and what we are, and that we are good, conscientious, quality, professional physicians, and not somebody who just is on the last lap because their license was withdrawn.
Charles, in your experience, how do the healthcare needs of incarcerated individuals differ from those from the general population?
Because of the extent of the illness, they've been on the streets. I feel, and I've said, now I haven't done the math, that many incarcerated persons are 20 to 40, their bodies are 20 to 40 years older than their chronological age. I've gone to many places and I see somebody 40 and 50, and with all due respect to them, they got so many illnesses, amputations, have severe diabetes, asthma, and that was from a hard life on the street. And fortunately, chronic care programs are throughout the country to help these patients because they need it. So patients, I am convinced that their bodies are older and more needy than their age because of their lives. The other issue is the mindset. It takes a while for someone incarcerated to understand the goals of the medical people. They think the goals of medical people is to cure every illness they have. They had a sebaceous cyst in their left ear 20 years ago, and they want that removed now. Well, that's not appropriate. And when I do surveys, I sometimes have to discuss that with, and I don't tell them, oh, no, you don't deserve that. I try to tell them, well, we prioritize. Same thing with dental. We have to prioritize that. And patients who are incarcerated don't understand that we are not there to provide every medical solution to every issue they have. And sometimes they get angry. I don't mean physically angry, but then they'll put in, they'll send notices here, and then they'll do lawsuits. And hey, it's part of the, I don't want to say part of the game because it's not a game, but it's part of the system of managing patients that are in that setting, the incarcerated setting, and needing good medical care because they didn't get it before and because their bodies have aged.
Charles, you mentioned doing surveys, and I understand that you've really gotten into doing NCCHC surveys since you retired. As a matter of fact,
yes,
you've done, what, hundreds, literally? How many have you done?
That's the one thing I did look up when I saw the questionnaire. I've been to 280 cities in 42 states. I have interviewed thousands, probably a couple thousand of patients. And I haven't been to Alaska, North Dakota, Rhode Island, Iowa, Utah yet. And I probably won't go there. I'm going to Puerto Rico in December, but I've done a lot and I love it. I love it. The role and what we do is, the first thing we do is look through the medical record to see about the care that they have received. The other thing we do is to talk with the providers, the staff, the correctional officer, and of course the patients. And I love doing that. I love doing that. And whenever I go to a yard, not all, but many of the inmates will look at me. You know how they look at you and say, who's he? And they'll come up to me and say, who you? And I smile and I always say, who do you think I am? Invariably, they say, you a preacher? Am I the preacher man? Because I always wear a shirt and tie. I look, presentable. I say, no. I smile at them. And then I say, who else? What's number two? They say, you from headquarters, you DOC? I say, then they'll give me, are you a lawyer? Are you here to sue? No. Well, who are you? The game was getting old. So I say, hey, I am a physician. I'm part of a healthcare survey team. We're here to evaluate the quality of medical care that the patients are receiving. That's when I get barrage of complaints. And I usually have to calm them down. I says, okay, I'll see one person who, very, not agitated, but aggressive and wants, so I'll talk with that person first. Then they'll line up. And I'll say, well, I can only see about maybe 4 or 5 of you, and I'll take this 4. And I talk to them. And, it's funny because invariably they exaggerate. Because after I talk with them and get their issues, I go back and look at their medical record. Invariably, it's not the same that they tell me. And I've had a couple of good experiences, and I'll say this real quick. There was one guy who had a bad hip. It was bad. He had already been to orthopedics and was evaluated, and they recommended hip surgery. And he wanted to know, why is it taking so long? I said, let me look into this. So I went back, pulled out his medical record, talked to the medical people, and I saw they had scheduled the patient. They had addressed the issues. And I says, okay. So I was going to go back and tell him that, yes, they have not forgotten you, It just so happened that when I got to his cell, custody, transportation was there, getting him ready to go out for his surgery. He looked at me as if I had done a miracle. He gave me all the credit. Thanks, Doc. I said, you got this done for me. Thanks a lot. I really appreciate it. Then he went out for surgery. There was a second guy. He was in the kitchen. And I walked up to, the dining room, the ODR, the officer's dining room. I walked up and said, hey, how you doing? He says, Doc, I got this thumb, blah, 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 and no one's doing nothing about it. They always say nobody's doing anything about it, which usually is not accurate. I says, okay, let me look into it. I never make a promise. They say, don't make promises you can't keep. I never make a promise. It just so happened the next day, I was down in intake and receiving. That's where the patients go to get prepared to go out off site. And he was sitting in a cell waiting to go off site, looking at me again, same thing. Thanks, Doc. I appreciate what you did for me. I'm going out for my surgery now. So those were some of the good, the interesting, I don't say the fun things about it, but it makes it all worthwhile. So that's what it is.
Many people realize the difference jail and prison medicine. Would you be able to share your perspective on how these environments shape medical care and the particular challenges that each setting presents?
Yes. In prison, they're going to be there, as they would say, for a minute. They're going to be there a while. So chronic care can be done better. It can set up more of a routine. They may be seen every 3 months, 6 months, or even a year, depending on their condition and their status. And they get used to that. They begin to know more about what chronic care and chronic management and chronic illnesses and diseases is all about. They'll still get their sticky buns and their ramen, but, they will give a better understanding of what it is. The docs and the providers in a prison have more time to work with their patients, particularly mental health. That's extremely important. I've asked a lot of people, what percent of the people here have significant mental illness? They all say in about the 40% range. Well, you can work with the patient. You can have groups. You can have a long medication program. In prison, they're not there. Some will be, but usually it's not more than 1 to 2 years, depending on the state law. And it's a little bit more hectic with patients coming and going, and different patients. And by the time you get a program set up, the patient's leaving. The patient may leave the next day. You are getting ready to do, the patient's going to be leaving soon, so you have discharge planning. You sit down with the program, who you're going to call out in the street, and what program. Next thing you know, they come back and they packed up and they're out of there. So it's different. Another difference is drug and alcohol intox or detox and issues. In jail, you see a fair number of people who come in drunk or high. You don't see that in prison. And that's not to say they can't get drunk or high in prison, because they do. But it's not as extensive and pervasive as it is in jail. Jail may get hundreds of intakes a day. Some get much fewer. Some may get 2 or 3, but it depends. I was at the Las Vegas jail. They got, the intake was loaded. People lying all over the place, not lying down, but not lying with their mouth. They were doing that too, but lying down all over the place. So to answer your question, in prison, I think that the providers have a better opportunity to work with the patients in managing their chronic illnesses, in managing their conditions, and in mental health, getting them to work with groups, with medication and other. Whereas in jail, you may not have that luxury. So I think that's one of the biggest differences between the two. The other thing is, when you go to jail, and you get a initial intake and a physical within a couple of weeks, at the maximum 2 weeks. When you go to prison, you've already had that, or it's done at the intake facility. Each prison system has a prison that they call the intake. That's where all the new people from either town, the street, or from jails come. Rarely does someone come off the street to a prison unless they're a parole violator. Parole violators will be picked up and in some states taken straight to prison. Now you got to do the whole workup. But I think the biggest difference is the ability to work with the patients over a period of time. Another difference, and don't quote me on this, is my observation, is suicide. It's my understanding, and I've seen it to a little extent, that patients in jails will commit suicide earlier than those in prison. Because those in prison, they've been through systems, they know they are beginning to acclimate. So they'll say, I'm going to be here for the rest of my life. I'm tired. I just can't do this anymore. And then they may either commit or attempt suicide. Whereas in prison, it's the person who's off the street, usually an older gentleman, and it may have been some, sexual type crime, and that they just, I think Epstein is a good example, don't want to stand it. So that period in which you have to manage mentally them to ensure their safety for suicidality, I think is also due.
So when all the facilities that you surveyed, 289, did I get that right? Anyway.
280.
Yeah, 280. Give a shout out to one or two particularly well-run jail or prisons that you've done.
Okay. I usually, once I walk out that door on the last day, I forget about them. However, there was one facility, it might have been in Texas. It was a public health facility. I was really impressed by them. From the beginning, when we walked in, there was an audience of 50 people sitting there. Some of our intakes, you're lucky if you get 4 people there, other than the surveyors. There must have been 50 or 60 people there. All part of teams, custody personnel, of course, medical personnel. Throughout the tours and the surveys, I could see that they were serious about meeting the standards. And then on the exit, they had a photography team there. They photographed everything and presentations. I was just impressed. And they did well as far as the care of the patients is concerned. Other than that, they're pretty much the same. Now, here's the challenge. There are roughly, give or take, 5,000 correctional facilities in the United States. There's only 500, give or take, 10% that are requesting accreditation. What about that other 90%? I don't know, but I worry sometimes about what goes on there. You wonder, what is the reason people want to be accredited? I come up with a couple reasons. One, court order, AKA California. They cleaned up their act because the receiver made us. Second is sometimes the provider who's going to give the health care will make it part of their contract. Say, if you select us, we will ensure that your facility is accredited. And then there's the other number of wardens and other that they just want to give good quality care. Now, it's not cheap. So a lot of factors go into this. But just to repeat myself, those that are accredited are the ones that do good. Now, in some locations, Georgia is one, in which Georgia surveys their Georgia facilities. California, same thing. So I'm not saying that none of that other 90% never get surveyed, but it's different processes. And I think that having an independent body such as NCCHC makes a difference. We don't have any any goal other than to ensure that they provide quality care. But if they do or don't, if they are or not successful, we're willing to help them. But it's not a inside help, it's an outside help. I hope that made some kind of sense.
Charles,
Yes.
given your extensive experience in incarcerated healthcare, what do you believe are the most critical skills and qualities needed to be successful in the field of correctional medicine?
Respect, patience, understanding, and of course, medical knowledge goes without question. Respect and patience, because these patients, they'll play you. They'll play you. But that doesn't mean that they don't have a illness. So respect them, understand them, have patience. Never get angry. I've seen some providers get a little bit perturbed when the patient doesn't do what the provider wants them to do. Patience, understanding, just got to have it. You got to have it. And a dedication. Well, I think most docs have the dedication. They want to, have the right thing, take care of their patients. So that's not it's important, but it's not a concern because, they have dedication. I guess nothing's 100%, but, a good 90, 95% of docs, they have dedication. And that's one of the reasons, that may be part of the reason they go to corrections. They do want to help those underprivileged. Many, it's a second profession. And I think that might be in the future where we can draw more people who are, quote, burned out of their day job. They get tired of the billing. They get tired of the lawsuits. They get tired of meeting, not meeting guidelines, but having to document in a certain manner such that they can get paid. And then sometimes you get rid of that. Come on down to correction. And that's what I tell them when I give presentations. Tell them the advantages. I also give them a heads up. Hey, you're going to get sued. However, if you have practiced defensible medicine, not defensive medicine, but if you do the right thing, you'll be vindicated. And that happened to me. I was sued personally. I had to go to federal court. There's a guy that had a urinary tract issue who was hoarding urinary supplies, catheters and bags and this and that, some of which were outdated and I don't know what else he might have been making alcohol in the bags. Anyway, when I found that out, I asked one of the nursing staff to go and take all of his excess used and old urinary supplies and give him more and keep track of what he's getting and make sure it's an exchange. Well, his allegation was that I'd confiscated all of his necessary medical urinary supplies. So I was sitting up there in a trial for 5 days, scared to death, not knowing what's going to happen. Fortunately, or rightfully so, the jury turned a verdict for me in my favor, at which time I was speechless. And show you how sentimental I am. Tears came to my eyes. And the jurors wanted to come up and explain and talk, but I couldn't talk. I went to the back of the courtroom and put my head down. Tears of joy is what they were. And after I left the courtroom with my tears of joy, I walked straight across the street to the bar and got rid of my tears and relaxed again. So I know I'm a little bit off topic, but that was just the experience of being sued. So I tell docs straight up, you're going to get sued. And 99% of the time, you are vindicated for different reasons. No merit, or didn't have a lawyer. It just wasn't a case, et cetera. But, correctional medicine is wonderful, wonderful. I want to say it's fun, but that is maybe misleading. But you're doing so good for these underprivileged people. I'm going to repeat myself, and they appreciate it. They appreciate it. 2 quick stories, if I may. One was a guy who was an eater, a swallower. he swallowed everything from light bulbs to water sprinkler system. And we would send him out and they would operate and he would come back, and he was under mental health also. And after seeing him so many times in the clinic, I sat down and started talking with him. And many times he would come over for whatever reason. I would go and say, hey, how you doing? And he says, well, I'm doing pretty good. I haven't swallowed anything. I said, that's good. I'm glad to hear that. Every time I would come down, hey, Doc Lee, how you doing? I've been behaving myself. Okay. Shortly after that, I retired and left. It's my understanding, and I don't know this for a fact, but a couple of people have told me that he didn't have that personal relationship. And he went back to swallowing again. They sent him out, had surgery, and he passed on the table. So that's something that is impressed on me about how developing a relationship with the patient within boundaries now. I mean, don't do anything illegal like hoarding up stuff and bringing him medicine and giving him drugs and stuff. No, you got to have appropriate relationships. There was another guy who I had a similar experience of communicating, and he told me that he was a murderer. He had killed women, sexual crimes, a predator, and that he wrote a book about it. I says, come on, man, what you doing writing a book about it? He said, yeah, I wrote a book about it. So he got the name of the book. I went and bought it. I don't know if you can see it, but this is the book. You can't really see it. But this is the book that he wrote, and his name is in it. So I don't know how to answer. I was surprised that A, he had written the book. 2, for once, he had told me the truth. And 3, that what was in the book is what he had said. So those were a couple of the interesting type experiences that you get in a prison setting. They got some good stories, some very good stories. I don't mean good as opposed to bad, but good, interesting stories.
So what's the biggest challenge, or where are we right now? What's the status of correctional medicine, and where is correctional medicine going? What's the big challenge for us?
Biggest challenge is getting adequate numbers of providers, docs, who want to do correctional medicine. The other challenge is recognition, continuing recognition. Conceivably, at some point in time, a goal of board certification in correctional medicine may be premature now. The third thing is getting adequate numbers of docs. We need more docs. The next is a training program. As we know, there is one in Florida. We need more throughout the country to meet the needs. Right now, it's my understanding, correct me if I'm wrong, that each year they have a person in training. But once a year is not enough. We need large numbers. Having, like I said, a residency, getting the word out as to who and what we are. Those are the challenges and those are the goals. And I'm convinced that correctional medicine is as noble a specialty and probably more difficult, because when you're sitting in that office, you don't know what patient is going to walk in next. Either you don't know his illness, you don't know his disease, you don't know his attitude, you don't know his motives. And many, many, many providers have told me, hey, I see a lot of illness and disease here. I've seen things that I would never see on the outside. So those are the values of correctional medicine. And the patients incarcerated really need good health care, good medical care. They are humans too. I heard a mayor of my city, and I called him out on it, called a sexual predator a monster who should be put away for life. My mayor, I voted for him. He's a good guy otherwise. So I sent him an email saying, wait a minute, these are people too. They need help. They need a place to live. They were going to put a sexual predator in the neighborhood where I live. And a lot of people were concerned and upset, and I understand that. But for the mayor to call them monsters, I just couldn't handle that. So I told him in a pleasant manner that, they're not monsters, they're human. He didn't respond back, but he got my message.
What benefits do you believe this recognition of correctional medicine as a distinct specialty and in designing high quality medical training education programs for our physicians and our healthcare sector, what will this recognition bring to our providers, our patients, our families, and our society in general?
One, and maybe first and foremost, is pride. Pride that we are serving underprivileged people. And particularly amongst our fellow docs, I hold my head high when I say I work in a jail. I was at my medical school reunion. I think it was the 60th reunion, something like that. And again, we were going around introducing, giving them an update as to what we do. When they came to me, I says, well, after I left medical school, I went there and I did this, and then I went in the Navy, and then I went to jail. I saw jaws drop. Oh. So I then said, well, I went to jail as a physician. Eyes lit up. Then people wanted to hear about it. They had now had an interest, realizing that I wasn't an ex-con at the time, realizing that I was a proud doc helping to take care. So pride and numbers. I believe, I think, I feel, I hope that by getting our name out there, getting our status out there, more docs will say, hey, that might not be bad at all. I'm tired of billing. I'm tired of, disgruntled patients. Maybe I'll give this a shot after I retire. I know many, they thought of docs. Jeff is one, for example. And it's a good thing. And maybe that's good for both, because these are docs who are experienced. They haven't just been, out of school and go straight. They've been in patient care, emergency room. Even there was one doc was an OB doc. And, hey, we welcome any and everybody. They got to learn about the, correctional medicine. But so pride, more people interested in it, all of which will be a good thing for the patients and for the docs. I'm proud to wear it. You see, hey, I wear it. Any correctional thing I go to, I wear this. I'm going to wear it out soon.
Jeff, is there anything else that you would like to add or share today in our YouTube podcast channel and our interview with Charles?
No, I've had a very enjoyable hour talking to Charles. Charles is always very fun to listen to, has great stories. So thank you, Charles, for coming and talking to us.
Hey, it was my pleasure. And you reach a point in time in which you love to talk about yourself.
Yeah.
And tell people what you do and what you've done. And doing it with correctional medicine, it adds something to who I am and what I am and where my head is. So this is my pleasure. And I thank both of you for allowing me to be on this interview.
Charles, I want to extend our deepest gratitude for sharing your profound expertise and experience with us today. Your leadership and dedication continue to inspire and guide the future of correctional medicine. Thank you for spending time with all of us today. We are all looking forward to further exciting conversations with our esteemed healthcare leaders and professionals in the field of correctional medicine. We will stay tuned to hear more from our esteemed and talented guests.
Thank you again.